All right. So we are talking about post-arrest care today. We're talking about the things. We're talking about the things that you could do for your patients to make sure, the little things that you could do post-cardiac arrest when you get ROS to make sure patients are doing well. And for that, we're going to start talking about, you get ROS, what are the things that I like to do? And I'm going to break it down to the first 15 minutes, the first 45 minutes, and then things that are kind of ICU-ish, but things that I think are very, very important. And Adam, I know you're very opinionated. I want you to jump in and let me know if I'm going astray, things you agree with, things that you do differently. Now, I will say that most of this is ED focused because that's where a lot of patients come straight in cardiac arrest. So I based most of it on this, but I don't think this is any different to a patient that you find on the floor. Adam, I mean, would you agree? Kind of some of these patients coming in on the floor are kind of like the emergency department.
Yeah, I mean, I think it's really similar. We have the advantage of having morning labs for the most part.
I don't hear you now.
You can't hear me at all.
Oh.
Hello, hello.
Where did you go, my man?
You can't hear me? You should be able to.
Go ahead, Adam. Say something.
Can you hear me? Can you hear me? How about now? Can you hear me now? Hello.
No more echo, but that's, I think, because Adam's not saying anything.
You can't. Now I'm gone.
All right. Adam, I'm going to go ahead and check your audio. I don't think you really did anything different, but go ahead and check it out, and I'm going to keep moving, and then we'll go from there. Let me see here. Interview mode. Let me check here. The question is, can you hear Adam? That's my question to everybody.
Yeah, can you hear me?
Can everyone hear Adam?
Hello,
All
hello?
right, so we're going to wait to hear from Adam. Check the chat. People are commenting. Thank you for your help here. So the first thing I like to do post-arrest, and this is going to sound very obvious, but very, very important, don't forget to cycle the cuff frequently. We get ROSC, we get a pulse, everyone's high-fiving. We're trying to figure out where in the hospital the patient needs to go. But the most important thing is to remember to cycle the cuff frequently. And I like to put this on every 3 minutes. Every 3 minutes, because I don't want to have the cuff cycling on these automated cuffs every 15 to 20 minutes. All right, so people hear you, Adam. That's great. I'll have to figure out why I don't hear you. So cycle the cuff frequently. The other thing that's very important is to get capnography, end tidal up, because this is going to be tremendously helpful to tell us what the cardiac output is doing. You have a patient and you get ROSC, the end tidal might go up to 50 or 60, and that tells you that you're getting reperfusion. Great. But as you're working on that patient and as you're managing them, you might notice that the end tidal is starting to drop. It goes to 50, it goes to 40, it goes to 30. You might think that the patient's hypoventilating, but don't forget end tidal is also tremendously helpful to help us to monitor for perfusion. So it's not just a ventilatory thing, it's also a perfusion thing. Be very cognizant of that and be sure to monitor your patients for that. So look at that end tidal. The last thing, and this is just something that I like to do, but it's helpful for me because sometimes I get really wrapped up in what I'm doing for the patient, and that is very, very important to put the pulse oximeter to that auditory feedback, that beep, 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 because as that's happening, I'm listening to the patient's heartbeat. I'm listening to their saturation. I could be doing procedures for that patient as we're going, but I have the auditory. I don't have to have someone yelling out commands or what the sats are as we're moving. So cycle the cuff frequently, get that end tidal up, that waveform capnography up, and then get auditory feedback. Adam, what do you say about that?
Yeah, love it. Can you hear me okay? We're good now?
I can hear. Yeah, I hear you now.
Perfect.
Yes, my brother.
You know, I know you're a big fan of this. It's not dissimilar to a code in that I assign roles. So, for example, you're talking about the blood pressure or the SAT. You know, I sometimes like to name someone the 90-90 guy. And so your job is to tell me if the SAT's less than 90 or if the systolic is less than 90. If it's not, I don't want to hear it because, you know, if we can eliminate excess noise, especially in confusion, it's always going to be better.
I like it. All right, the next thing is fairly obvious, but sometimes gets forgotten. You got to get an EKG. Now, most of the codes that happen out of hospital, coming in the hospital, are ischemic type events. The ones that are happening in the hospital are sometimes ischemic, sometimes hypoxemic, sometimes PE. It is very, very important to get an ECG early, because if there's a STEMI, they got to go to the lab. You have a reversible lesion. This is going to change their outcomes. You're looking also for STEMI equivalents, not just a true ST elevation MI, and also get serial ECGs. One ECG begets another ECG. I'm aggressive about looking for a reversible cause, because again, if there's something I can fix in that patient, well, we're going to have a better outcome for that patient. And Adam, any things to say differently about that, or you're on board with an EKG early?
No, I love it. I love it. We get
Good.
fixated on things like access and location and basics. Get the EKG, get the ultrasound. Every single time I'm going to a code, the ultrasound's coming with me, and the probe is certainly on during CPR when possible, and it's 100%. I do a full exam prior to moving the patient once I get ROSC.
Fantastic. Now, look, again, remember, these are the first 15 minutes. Some people that are going to have other things that they want to do. These are the things that I do immediately in sequence post-rest. So please keep that in mind. Also keep in mind, don't forget to like the video and subscribe to the channel. That we're going to plug that a lot more during this thing. All right. In all seriousness, next thing I like to do is ultrasound. Now, I know Adam's a huge fan of ultrasound. That's one of the reasons why we have such a deep love for each other. But ultrasounds is important intra-arrest. But don't forget to get a thorough ultrasound post-arrest. Intra-arrest, let's face it, it's chaotic. Your windows might not be very good. You might just see some things, but you have to do a thorough exam if you get ROSC. Go through whatever type of rush exam that you do, looking at the heart, looking at the pipes, looking at the lungs, do a thorough exam, because you might be able to see something reversible or confirm something reversible or find some wall motion abnormality. But during a code ultrasound, I find it to be very limited, even in the most experienced hands. Take your time after the code while everyone else is doing stuff to do a thorough exam and rule in the things that you think might be going on, or take some things off the table. And I'm pretty sure I know what Adam's going to say. But Adam, why don't you go ahead and say this while I turn off the AC? It's creating a lot of ambient noise. Go ahead.
So yeah, I always find the intracode ultrasound exam fascinating, and the things I'm looking for, and I know Haney's going to talk about his VFib, his VFib patient that's PEA, and whether you shock them or not. And I don't want to get too far into the weeds of that. But when someone's coding, all I'm looking for is pneumothorax, which people always immediately think of lung sliding, which is so hard to tell when someone's doing CPR. So I look for B lines. I think it's just as strong of a predictor in this scenario. If I have B lines, I'm not putting a needle in. I know the pleura is approximated. And then, of course, large effusion, something that I need to do immediately. And then once you have ROSC, well, then we move into, I really want to understand what the LV is. I want to understand the LV to RV ratio. I want to make sure that there isn't a big pleural effusion or big pericardial effusion, or, and I take my time to go through it. And I think that's the EKG. And then the other thing we didn't mention was point of care glucose. I think it's frequently missed, but, those are things that you're going to get immediately, because all the labs and all those things, sure, you got to send them, but we all know it's going to take time to get those results back.
Yeah, I totally agree with that. And when it comes to labs, I agree. Fingerstick is one of those things that often gets forgotten. It doesn't typically cause cardiac arrest, but when you miss it, man, I mean, it's just one of those things where you're like, gosh, I forgot the fingerstick. So always remember that. And in line with that, we should be getting certain labs. Now, I know everyone sends a rainbow of labs after their arrest, but there's some key labs that I think are truly important. And obviously, a blood gas for me. And we have at our hospital a blood gas. I call it blood gas plus, but it's blood gas with electrolytes. It also has some hemoglobin. It has some key things to tell me early on why this person could have arrested. I like to get a lactate. It's not something I'm going to go ahead and say, oh, the lactate's 10, I need to give fluid, but it gives me a prognostication of how bad this person is off. How long have they been down for? How sick are they? It's just a marker for me of how much I have to resuscitate that person. When the patient comes in the ED, I personally like to get labs for toxicology. And when I say toxicology, I mean the pills that kill. Things like acetaminophen levels, salicylate levels, and toxic alcohols. Those are the things that can kill the patient if I'm not aware of them. And again, in the ED, I do like to get a set of blood cultures on this person. I don't necessarily send it, but I keep them to the side in case we get a little bit more historical factors telling us that this person actually went down because they were sick at home, they're bacteremic, and then they coded. But at least I have that stuff before I go ahead and give them antibiotics. Adam, any other labs that you find
No,
helpful to send for your patient?
no, that's great. I love that. I'm gonna put you on the spot though. This is a game I like to play, which is if you're only allowed one lab value, and BMP is not an answer, just one specific lab value. What do you take? I'll give you any, and this is for you to understand kind of how sick they are. And this doesn't have to be post-code; it could be just really any patient. So I know my favorite. What's your favorite?
I have to pick one.
You only get one.
Desert Island. I only have one lab to send. Why don't we have people drop it? I'm going to say what mine is,
Yeah,
but go ahead and
actually,
drop
that's
in
a
the
good idea.
comments
Yeah.
what everyone would say. I'm going to say pH. I'm going to
Oh, see,
say
that's good.
what? What? No, you're
No,
going to
no,
say,
no.
oh no, you can't
I
say
was going to say
pH.
bicarb. I was going to say bicarb, and I think pH
Okay.
may actually be even better. But
Okay,
yeah, I
bicarb's a good one
agree.
though. I mean, definitely one to know, and we'll monitor the chat to see what other people have to say. But how about on the floors? If you're going to see a code on the floors, any specific labs that you like to have or like to see?
No, I think you hit them. I honestly don't send cardiac enzymes. I think they get sent, but that's not high on my list. The troponin, I think you have to, but for me, a BMP, obviously CBC. I send it ABG on every patient. I I I don't want to get into this venous versus arterial because I'm sure we have differing opinions. But I like to joke. The only thing a VBG tells me is that I need an ABG. And so I'm a fan. I'm a pulmonologist at heart, so I'm a fan of an arterial blood gas. And I'm trying to think what else. Those are most of it. The hemoglobin and potassium that's on the ABG plus that you were talking about. I don't know how reliable they always
Mm-hmm.
are. Um, I usually use them to confirm. I am hesitant to react to them, but it definitely I look at them because the drop in if your hemoglobin is actually 6, it will be 6 on the blood gas too, right? There's
Mm-hmm.
never falsely elevated,
Right.
but yeah, I don't always like if I see potassium of 2 on that, I don't just start slamming potassium in them.
Great point. Great. Yeah, they're never one where I'm going to act on and start doing stuff. But if I have a pretest probability and it comes back, higher than what I thought, then I'm certainly ruling it in, and we'll keep going along that track. Certainly, I've seen potassiums that have been elevated. Lots of people, by the way, and dropping in the comments, potassium is the thing that they look for. That's helpful, right? Because that's an instant therapy that you can give the person. Calcium, you're going to get your BNP, get things going for the person. So I think that's helpful. All right, good. All right, let's talk about intubation and airway because, I'll tell you when I respond to codes on the floors or even when they come in the ED, there's this temptation to make airway the first thing that you do. So the person might have an LMA or they're bagging the person and everyone just wants to get the tube before any of the stuff that we just talked about. And my pet peeve is, if they have an LMA in, which I think all cardiac arrests should have an LMA in, you can manage them pretty far down the road just with that LMA. What do you think about that, pulmonologist?
That I think it's a great thing, and let's be honest. Supraglottic devices aren't usually used in the inpatient setting, right? Um, that is very much a ER EMS maneuver, and it's probably underutilized. I think that I like to tell this story about this anesthesiologist I trained with, and she used to make her interns do proper bag mask ventilation on simple cases the entire time and wouldn't allow them to intubate. These are elective OR cases. And the point being that you can oxygenate and ventilate someone just fine with really good bag mask ventilation. And so I do not rush to get the airway. I will say 10 minutes is my limit, about 2 rounds of CPR. And I like to have an airway in. But we've also all been to those cases. I don't want people to generalize this too much. We've been to those cases that are clearly hypoxic mediated. Those you got to get a tube in, right? I mean, how many intubations, how many codes have you been to where you put the airway in and then you immediately get ROSC, right? Those are, and so you have to assess, is this patient aspirating? Do we think that this was a upper GI bleed and they've now have all blood throughout their lungs? and because I think that matters in terms of when I put a definitive airway in.
Yeah, it's a good point, and it's one that we probably can debate for a while. There's no clear consensus. What I will say is that if you are going to put that airway in, and you say, I'm going to endotracheal intubate because I'm worried that there is a pulmonic component to this code, please, please, please do not stop chest compressions. Do not detract from everything you're doing. Don't let, I'm not calling any group of people out, anesthesia. Don't let any of them tell you to stop doing chest compressions to get the airway in. It is vitally important that if you're going to go for that airway, use video and make sure that through chest compressions you're doing it, or get yourself set up so that when it's time for that rhythm check, that it's rhythm check, go get that tube in place, but do not stop for chest compression. All the data shows us that that's where harm happens, is decreasing that chest fraction, the chest compression fraction. Yeah?
Yeah.
Okay, cool. All right, so that's the next step. The next step also in this 15-minute foray is to make sure that whatever vasopressors you're using or whatever antiarrhythmic you're using, get those up in continuous doses. You've probably been using boluses during the duration of the code. You have to shift gears and saying, let's get something continuous. If you gave epi and you think epi works, then use epi. There's more and more people who are using norepinephrine post-arrest and intra-arrest for that matter too. Get that up and get it running continuous. You're better off pushing your map a little bit higher, right, post-arrest, than letting it drift down and keep bolusing up with ampules of epi and letting it go up and down. Get something continuous and get that mean pressure up so that you can continuously perfuse the coronaries. And the same thing is true if you had some sort of ventricular arrhythmia and used amiodarone, and use something continuous for that person post-arrest. Adam, what are your thoughts on continuous doses of medications?
Obviously 100%. And we usually have an abundance of people there. So I am asking for those drips to be made and available during the cardiac arrest with anticipation of using them.
Yeah, great point. Definitely utilize the people in your room. Make sure that they are, there's always more than enough people in the room. Make sure that they're there doing stuff and give them a role, something to do. They feel good about it. The patient's going to benefit from it. The last thing I'll say, speaking of people in the room, is don't forget to debrief your team. Sometimes post-arrest, people are sweaty, people are exhausted, people start to scatter out. This is the only opportunity that you might have to better your team for the future. So I tell people in 15 minutes, we're going to step outside for a 5-minute debrief. You can always debrief more. You can always debrief later. But if you don't take those 5 minutes, you'll never get back. Things will never get less busy on your shift. So you might as well take the opportunity to highlight the things that were good and let people know the things that could be done better last time. You'll be surprised to find how little team leaders debrief their team. And they're so grateful when you just take some time out and say, your chest compressions were too slow, or I really like the way you organized the team, but give your team feedback. And I do it sooner rather than later because I find I never get back to this.
Yeah, I have so many opinions about debriefing and the utility of it. And let's be honest, if the patient expires, it's a lot easier than if you got ROSC. It's so frequently, it's just they have procedures, you have to move them. It's just really hard. And so I think that we need to debrief. We need to do it more. And I always talk about, I wish we could build what I call a culture of debriefing, right? And it's just, it has nothing to do with pointing fingers. It's like, let's do better next time. And on the other hand, if someone does an outstanding job, it's really great to point out how awesome they did. That is definitely underdone. Oh,
absolutely
and look,
agree.
I'm looking at Dr. Bonk. The one value he would pick is type and screen, it looks like. That's an interesting, Dr. Bonk. That's interesting.
He must work in a trauma unit where the only thing that happens is hemorrhage. So totally agree. And the last thing I'll say about simulation is, or debriefing, is don't wait for simulation, right? In the moment, time of impact, that's the best time to give feedback. All right. That's the first 15 minutes for me. Adam, I appreciate your input into that, your insight. Let me take you through the next 45 minutes for this. And this is what I call the fine-tuning post-arrest. These are the little things that could hold you up that you might think they're kind of we can wait till you go to the ICU, but these are the things that really do matter, and things that if you're in the emergency department, you should be responsible for as the emergency provider. If you're on the floor and the ICU is came and went, these are the things that you should be following up. So I think this is a underutilized period of time right here. And the first thing, post arrest, respiratory comms, they put them on 100%. They put them on some, random generic settings for the patient, and that's all well and good in the moment. But now is the time to go back to the patient and ask the questions: are our settings appropriate for the patient, for their sex, then their height, ideal body weight? Are we giving them the right oxygenation? Are we giving them too much oxygen? There's data that shows that patients post-arrest are damaged by hyperoxia. There's even an emerging body of literature that's saying that CO2 being too high and too low can be harmful, very in early stages, but just something to think about. But the first thing that I do in this next set of things is I look at the blood gas that I sent, and I try to bring down that FiO2, get the settings to more appropriate settings for the patient who's in front of me. What do you think about this, Adam? Too much or just right
No, I
at
think
this point in time?
I think that's great. I think that's great. I think about all of those things as well, and I specifically, let's talk just briefly about the ventilator. You're mentioning hyperoxia, and I think that's for sure needs to be avoided, and we need to aggressively titrate the FiO2 down. The other thing I think a lot about is minute ventilation. So I may not have a pH, but if you have end tidal, utilize it. I understand that there's going to be metabolic components.
I think we just lost Adam Green. Don't worry, he'll be back on in just 1 second. Here he goes.
Sorry,
Hello?
can you?
Yeah, gotcha.
So I was saying hyperoxia, and then I was mentioning minute ventilation. I'm obsessed with the ventilator, and I'm thinking to myself, I'm using the end tidal. I'm thinking about what the pH I think it might be. If it's a long code, I know that I'm going to have a pH in the low sevens, like high sixes, right? So I am looking at my minute ventilation, and I'm targeting 10, 11, 12 liters per minute. I'm obsessed over what the airway pressures are, right? Especially if they're in shock and the peak airway pressures are through the roof. We know that that's going to diminish cardiac output and make things worse. So every aspect of the vent is important. The answer isn't always 16, 500, 105.
Such a pulmonologist. But I agree with you 100%. That's exactly true. Just try to figure out what's wrong with your patient, and best you can before that blood gas is back, try to assess the situation. The same thing is true if it was a ventricular arrhythmia, right? They don't have to be on 100%. You can trust your FiO2, you can trust your pulse ox on the monitor. But if you really want to wait for that blood gas, if you really want to be certain, fine. But just be sure you get that FiO2 down as quick as you can. All right, let's go on to the next thing. And this is where it's time to place some lines. You may have put an IO during the code. You may have put it in running everything through a peripheral IV. Now is the time to get your lines in. Now, I'm going to say things a little bit different than what people might have heard. The first line that you need post-arrest, if you didn't get it intra-arrest, is an arterial line. An arterial line is far more important than a central line for a few reasons. The first reason is you can get a central line in just seconds by using an intraosseous. And I would say that if you give me a person who has 1, 2, 3, or even 4 intraosseuses, I'll take that over a quad lumen central line. But I need an arterial line for a few reasons. The first reason for the arterial line is just simply I don't have to keep feeling for a pulse. I don't have to keep cycling the blood pressure cuff. I have it on the monitor. I have something to look at. If this person loses their pulse and they go back into arrest, I now have a monitor for the person for the diastolic blood pressure, which we can talk a little bit about if people are interested, as being the only marker I care about during the resuscitation. And then during our rhythm check, we don't have to go diving into the groin or the neck and try to feel a pulse. I can just look up at the monitor and see if we have a pulse back, sort of hands off, because we're all terrible at feeling the pulse anyway. So the first line I would get is an arterial line. And I'm going to intentionally pause there because I want to hear what Adam has to say.
Yeah, I think I understand your point. I have to think about it a little bit. I've been known to say that A line has never saved anyone's life, and
Ooh,
so
nice.
I have trained in an era where and in a hospital where arterial lines weren't even really a thing. So I think that I do think you're right, and I think that my world is a little different than yours, the emergency room, and that uh, most of the arrests I go to are on the floor, where even if I want an A line, they don't have the monitors to and the equipment to use it. So at this point, I will say I don't remember the last time I emergently put a central line in on a post arrest patient on the floor.
Hmm.
I always move them to the ICU first.
Yeah.
Um, what I'm thinking to myself at this point is how can I get them out of this room to my ICU? And do I need CAT scans? And can they survive CAT scans? That's what's going through my head. But you're right. If I need central access, I'm putting an IO in 100%.
Hmm.
Um, and my finger is on the pulse, and I'm cycling that blood pressure cuff for sure. But I get your point about A lines. I just don't know if I jump to them as quickly.
That's fair. And I definitely think on the floor, you're right. Even if you want an A line in, you're just not going to get it. And if you do, it's going to be more of a cluster for a group of nurses and techs who don't know that modus operandi. You're just going to create more problems. So better not to do it. I agree with you. The question is just in the ICU. And again, my take is I find more utility to getting it early. But we're on the same page though about central line. Central line can wait, right? We can get central access. We don't need to get the triple lumen in the groin. That's going to wind up coming out anyway as soon as the code is over. So get what you need. You can put anything you want through an IO. Literally, you can put anything you want, and the flows are pretty fast also. So I'm very happy with it as a resuscitation line, and more people should be using it. All right, we've burned a hole through the central line IO discussion. Obviously, Foley catheter for me early on is important because it's just one of those things that tells me how the body is doing. Look, if the person has a Foley and they're making urine, and forget about all the cauties and all that stuff. I know we're not supposed to be putting Foleys and all blah, blah, blah. But if a person is making urine post-arrest, things are going well for the person. You're resuscitating them well. And if the urine output's low, it gives me an indication that this person's hypoperfused and still shocky, and there's things I need to do. So while it's not like the most important thing, I do make the point of saying, you should get the Foley in as part of this initial package because it's part of your fine tuning. And then most of the Foleys that you're replacing are going to be temp sensing Foleys because of something else we're going to be talking about in just a little bit. So, Adam, I'm curious to hear your thoughts.
That's exactly what I hate Foley's and I take them all out. But that is the scenario. The first 48 hours of a TTM needs it. You need a central temperature. You need a central core temperature. Temp sensing Foley is the way to go. That's what I use. Yes.
Good. All right. Next point, and this is a point of controversy, and I want people to drop their comments here. But I'm actually gonna ask you this first, Adam. MAP goal post cardiac arrest. This literature base, I've been looking at it for many years now, and it's kind of all over the place. There's some that says, MAP of 70 is okay. Some people say a MAP of 90 is better for people in the first 48 to 72 hours. You have a patient who codes on the floor. We'll just give it to you that undifferentiated code. What say you in terms of your MAP goals for that person?
You're going to probably prove me wrong. I say 65 for everything.
Mm-hmm.
I target 65.
Yeah, and I can't prove you wrong, but there is data that have looked at those two groups of patients, and there's some that say that patients long term have better organ perfusion when it comes to a MAP goal of 70-90. I even know that there's Dr. Treziak from our institution has done a couple studies on this exact topic. But I'm really curious to hear what people have to say about it. I personally like to drive the MAP goal a little bit higher post-arrest, but I don't know that we have the answer as of yet. And it's one of those things where you can find the literature that you want to find and prove yourself right when you want to. But I'm curious. I do think that if someone has a history of chronic hypertension and they are their organs are used to seeing a higher perfusion head, in general, when it comes to any shock state, I'll drive their pressures a little bit higher. I was taught 65 as well, says T Brandy #1. All right, good. All right.
Haney, I do want to pause 1 second about that. It is so logical to say if you're on 3 antihypertensives and your systolic is always 180, like this concept of relative shock. And I wish we just had more literature that supported it. kind of the comparator, and I'll just mention it because I find it fascinating, is the relative hypoglycemia, right? So the patient whose sugars are always 300, they come in for a knee replacement, and then we make them 140, and they feel like garbage. And it's like, why are they so sick? Well, because their sugar's 200 points lower than what their body's used to. Very similar. But yeah, I wish it was like that simple. It's chronic hypertension. You target higher. But I don't know.
Yeah.
I haven't seen literature that supports it.
Yeah, exactly. I think that you can find literature that'll take you one way or the other way. The most important thing that you do is definitely keep them at least 65. We can agree about that. The whole kind of like they're drifting down to 50 and you're just waiting to see what's going to happen. You don't want to start a vasopressor. We can all agree that's the wrong thing. You have to have some minimum baseline. And I'd go even one step further and say you probably should be looking at the diastolic blood pressure anyway post-arrest and make sure that you're at least 35 to 40 of diastolic blood pressure to make sure that you're perfusing those coronaries. Because again, the heart is stunned right now, and you can argue that it needs a little bit higher for perfusion head post-arrest. Let's see. Mike Bonk says there's some good evidence in trauma surgery literature for targeting higher blood pressures. There you go. So type in screen, and if you're in a trauma ICU, higher blood pressures. All right, this is interesting. Please keep the comments coming. I love to hear. There's so many smart people that I recognize here in the chat. Love to hear your insight on that.
And before you go on, let me bounce back. I think there was a question earlier I saw, and I thought it was a really good one and worth bringing up. Is during cardiac arrest, if you have drips going, do you continue them or do you just push epi? My answer is it probably doesn't matter. Because if you think about the drip rate of norepinephrine of 20 mics per minute versus a milligram of epinephrine that we're pushing, it probably doesn't matter if the drips are on or off. I don't know if you agree, but
I agree.
That's something to bring up.
I would tell you that I think it takes more of a cognitive load to remember to push the medications every interval than to have them running continuously. And again, none of this that we're saying about cardiac arrest is really prospectively validated. It's hard to find any good data post-cardiac arrest. But if you're going to push epi, if you believe in epi, let's just say, and you're going to push it every 5 minutes, right? Then why not just put the bag up and run it at 200 micrograms per minute? And this way you don't have to worry about running it. Now, some people say the volume is going to be higher, and I can appreciate that. But just think about in the middle of a code when you're cognitively tasked with so many things, looking at ultrasound, manage routine, make sure chest compression deep. Now you have to think about another epi to be pushed every certain interval. It just takes one thing off of your mind so you can focus on the things that really, really matter for the patient. All right, so we talked about the MAP goal, or we didn't talk about the MAP goal. The other thing I like to do at this point in the resuscitation is I do like to remember to look at the heart again. Because if I find that I'm escalating my pressures and the person's still not getting better, I want to make sure that there's not something I missed or something hasn't changed significantly with the patient. Specifically, what I'm talking about is looking at the stunned myocardium that we have for a person who's escalating pressures. So I really like to say, okay, this is the point now when I'm getting my map to normal. Let's take another look at the heart. Maybe you don't need to rule out the reversible causes because you've already done that. But let's look at the heart again and make sure that it's not a vasopressor problem. We're not missing an inotropic problem, and we need to increase the squeeze. Adam, at what point, if at all, do you take that second look at the heart to make sure you're going on the right track?
Yeah, I definitely immediately post-ROSC, and then probably once settled in the ICU. That's probably my... Yeah.
Cool. All right, like it.
Unless there's a major clinical change, right? Obviously.
Oh, yeah. Yeah,
that's
for sure.
Scenario. Yeah.
Yeah, and that's important. And I see some of the trainees forgetting about this, but if something changes on the patient, your first move is to resuscitate the patient, but your next move should be why? Why did this happen? Don't just accept it that the person's pressure just tanked. Get the ultrasound machine, take a look. Get some new lab data if you think they need new lab data. Don't just take it on face value that this person just changed trajectory. Look for a cause, and oftentimes you'll find a good reason why, and then react to it. The last thing that I want to say just about this is to remember at this point, if your patient is escalating doses of vasopressors, this might be a good time to put in a call to your ECMO team for VA ECMO if you have that available in your hospital. And if you don't have it available in your hospital, then you want to start calling ahead. if you've ever transferred a patient for ECMO, you'll know it takes the magnitude of hours to get that person out of the hospital. And if your person's not looking good right from the jump, it's a good idea to start that process now, because it's still going to be several hours before they get it. Even when the transport team arrives, it still takes a few hours for that person to get loaded up. So start the process early. And I never hesitate to call cardiology to see if if an Impella would be appropriate, or an intra-aortic balloon pump, or even getting them ECMO. I know at our center we cannulate for ECMO, but not every center has that. Sometimes you have to call the consultants who have to come in from home, who have to call on the team to get things going. So I like to get that started at this point in my resuscitation before the 1 hour mark. What do you think, Adam?
Yeah, I agree. I always like to ask the question. I think the best doctors I've ever worked with are always humble, and they're not afraid of looking silly. So, I know you may read somewhere that the age cutoff for ECMO is whatever, 65, and your patient's 66. I still call. I have been surprised by decisions other people have made, and then they explain and said, "Oh, that makes sense. I never thought about it that way." So I always call and ask for help. And I agree. I think cardiology should be involved in all of these patients. As much as I love my POCUS, I think a formal echo within 24 hours needs to be done, and I think they should. Yeah, I agree with you. I always call early.
Yeah, and to that point, I just have to say this out loud, but we could say the same thing about calling cardiologists for something that's not a STEMI, or any other service. If a patient just died and you brought them back to life, and this person doesn't have stage 4 metastatic cancer and has some reasonable trajectory to live, why wouldn't you call? Don't assume that the consultant's going to say, "No, I'm not interested." I hear that too often, that I'd call them, but I know what they're going to say. You don't know what they're going to say because you didn't talk to them. I would rather be shot down and look myself in the mirror when I go home and say, "At least I tried," than saying, I thought I knew what they were going to do. Because like you said, you never know. Maybe that person is outside some hard bookend of an inclusion criteria, but fits in some other need. And they say, we're going to give this person a shot. So I couldn't agree with you more. Always give that person the best shot.
Yep. The answer is, I know it's not a STEMI, but I could use some help. Can you please come help me? And that's all that needs to be said, in my opinion.
I like that. Yeah, putting them in hero mode, I think, is always a good mood with the consultant. It's like, I'm not telling you, I really could use your expertise on this case. That's always a good move for consultants. All right. So for me, that's my first 15 minutes and my first 45 minutes. So we're up to an hour now. Before I go on and talk about the kind of ICU stuff, Adam, anything else that you think was that's part of your initial package for managing these patients that you want to bring up?
Yeah, I want to talk a little bit about CAT scans, because, and the reason, there's a lot of reasons, but when the patient's on the floor or in the emergency room and they're going to be moved to the ICU, that is the opportune time to do imaging, right? So I really, first off, they need to be clinically stable. Secondly, if I'm capable and I think they can handle it, then I do pan scan almost every single one, unless I have a clear reason why they coded. If it's a clear, the patient's been on BiPAP, their SATs dropped, they became bradycardic, it's clearly hypoxia mediated, then, or it's an obvious STEMI that rolls in, then I may not be scanning all of them. But I like my CAT scans. I like the CT brain. We can talk. I'm sure we're going to talk about neuroprognostication, and I don't rely solely on that CAT scan, but I think having that baseline scan immediately post ROSC is helpful. So that's kind of where I decide if I'm going to do it or not. And I will say, if I make a decision to forego it and bring them to the ICU, I'm not stopping TPM to then send them down for a CAT scan a couple hours later. I've made the decision to not do it. I'm not going to do it.
So if you decide not to scan them, TTM and all the way, no scanning in between. Okay, that's great.
Unless it's like, if their peak pressure's jumping, their belly's tight, and I'm like, oh, I think they have an acute abdomen. Unless there's like a real reason, but or they have a new blown pupil, and I think that maybe they're hemorrhaging in their brain. I'm like, I really need this. Then maybe we'll talk about it. But I don't do it for routine.
Right.
Yeah, for sure.
Yeah, that's a good point. Yeah, the CAT scan has become something which is very, very important, but sometimes bumps some of the other procedures that need to be done. Like the person's unstable and they're like, well, we need to get the head CT to prognosticate. Don't forget that person has to truly be stabilized. And for me, that's why I put it in the next hour of care, because I don't want to, unless I, like you said, don't know what's going on with the person, I'm looking for a bleed that's going on somewhere or something that I can act on immediately. I will put it to after the person gets settled on all the drips, has shown me that they're going to maintain their map and not go back into arrest. Then I'm going to get the person over to CAT scan. I completely agree with you. The other things for the last hour, and again, this is the next hour, these are things that some people call ICU-ish, but if you work in a busy hospital center like we work in, or many of you work in, that patient's going to be with you in the ED for quite some time. And if you push off the ICU stuff till the patient physically is in the ICU, you potentially can be putting your patient at harm. So I do think that these things are in our purview of care in the emergency room or on the floor, with the guidance of critical care. And the first thing that's so important, that's actually in the AHA, but we hardly ever talk about because it's a tough thing to do, is to do EEG for your patients who are unconscious post-arrest. And the biggest thing is you want to make sure that your patient is having non-convulsive status epilepticus. Again, it's in the guidelines. It's one of those things where it's an act of God to get a tech in, an EEG tech in during the middle of the night to do this. But it is important. It does change things. If you're giving your patient your best shot at resuscitation and make sure that physically they're okay, why would you leave someone whose continuous status upstairs, who's going to be worsening their prognostication once you rewarm them and get them better? What are your thoughts, Adam?
Yeah, so let's talk about this. So first off, it should be said, I'm not talking about, let's take the non-convulsive status out of the equation. We just have a post-code patient. It is standard of care to have a EEG done within the first 24 hours. That is supported. Every one of my post-arrest patients, I get an EEG within the first 24 hours. Now, I don't think that this necessarily needs to be a full montage EEG that the tech comes into it, does it. I am a huge fan of point of care EEG, without saying brand names. And I think that I can go
Don't
on and
worry.
on
Mike
about.
Bonk said it.
Yeah,
Mike Bonk
they
said
already
it
did.
already.
So for those of you who don't know, I should also, I guess this is the point where I should say I have a disclosure that I work with Cerebell, but I love it. It essentially what it is it's a headband. It's got 10 electrodes. It has AI technology that will give you a seizure burden threshold. So for those of us who don't know how to read EEG, it'll tell you if the patient's seizing, and pretty accurately. And so I put one of those on every one of my cardiac arrest patients within 24 hours, period.
That's great. So I agree with you. Again, I would prefer to get in a formal EEG, but get something on the patient. Be sure that you act to do something for that patient, because we lost Adam again, but he'll jump on. It's vitally important. And the last thing you want to do is let that person fry their brain post-arrest when you could easily find out what's going on with them and treat it and get them started on some anti-epileptics. All right, so we got that. Let me go here to my notes. The next thing, this is controversial. I don't think anyone is doing this. Let me just start off by saying this. But I put it in here because there's a little bit of literature that supports antibiotics post-arrest for preventing ventilator-associated pneumonia. I can honestly say that I'm not convinced about the literature, but I see it out there. Adam, antibiotics? After I say all that,
So
do you use antibiotics?
I've heard of them. So my view is if it pops in your head, like, oh, maybe I should give antibiotics, I do it. And I wait for culture data, and then I'm quick to de-escalate. So, and I think this is an important thing to say is like, I understand the length that we use for hospital-acquired pneumonias, for example. I understand the number of days, but if your cultures are negative, even if they have the infiltrate, but there's no sputum and they're not really acting infected, and you're like, oh, that's probably just pulmonary contusion from CPR, I stop them, and I'm quick to stop and observe off. I know your hatred for procalcitonin, so I do not use procalcitonin to help me decide in this scenario. If I'm worried, if they have a white count, if there's a concern, I start them and then I stop them after 2 days.
Yeah,
That's
I'm on board with you with antibiotics. I guess I should have prefaced it by saying that there's some data that says that
no, yeah,
patients who, in cardiac arrest get prophylactic antibiotics for
no,
that.
yeah, I
And
don't do that.
yeah, and again, the literature's not great, but I do hear it out there, and there are some papers on it. But if you were going to do it, I never do it ahead of all these other things that we talked about. This is after the first hour when we're just fine tuning some stuff in the ICU. If you're going to do it, this is the time to do it, not earlier.
I will say
Um,
I'm a fan of making decisions. So if the decision has been made to do it,
mhm.
don't sit around and talk about how you're going to stop it. Just do
Yeah.
it, commit to it, and then when it's time, stop them and do that. The back
Yes.
and forth is confusing.
It's true. And look, if you gave an extra dose of antibiotics and you decide to change your mind later on, you wouldn't be the first one that's ever done that. In fact, many people do that. But again, I like Adam's point. Don't sit on the fence. Do something and just keep moving. You got to keep moving with these patients. There's a lot to do for them. Along those lines, there's some literature, and I would say some pretty good literature. Maybe the best literature we have for patients who are in post-cardiac arrest is for using vasopressin steroids and epinephrine, that cocktail. And if it's something you're going to use for your patients, then don't forget the secondary doses for the antibiotics if they're going to be sitting downstairs. So if you went through the trouble of using that protocol, and this isn't the forum to debate it, although we can, then don't forget to give them the continuous dosing of antibiotics. That first dose is one thing, but then you have to maintain that dosing moving on. And then the last thing I'll say before we talk about cooling and some prognostication is I'm absolutely angered and maddened and just disgusted by maintenance fluids on patients post-arrest. Actually, just in general for patients who are resuscitating, every 100 cc's that you give a patient in healthy volunteers, let's say, only 20% of that is staying intravascular, 20 cc's. Everything else is going intravascular. Critically ill patients, a whole lot less. If you think your patient needs volume, then give them a bolus of volume for what you think they need by giving them a maintenance fluid of, to try and replete their intravascular losses. If you think they're there even, you're slowly just drowning that patient in crystalloids and making all the tissues edematous and worsening their outcome. That is something I can't stress enough. I hope Adam agrees with me on this one. Otherwise, I'll look like a fool. But I can't stress enough when I see people who are like 100 cc's hypotensive on 3 pressors. I'm like, all you're doing is you're just making the tissues edematous. Adam.
Yeah.
Yeah.
So a couple comments. First off, this concept of maintenance fluids is garbage. There are 5 indications, maybe less than 5, that I can think of for continuous fluids, and they're things like rhabdo, right? Like real rhabdo, or there's a very small number, and that's not really maintenance fluids. You're using it as a treatment choice, right? And the second thing is I challenge people to actually go in their room and calculate what the drip rate is for all of the medications that you're using, and you'll realize that they are getting more than adequate whatever maintenance fluids you've decided to prescribe. So yeah, I don't use it.
Look at this comment. This is great. As my
Yeah,
mentor
right.
said, I don't see you walking around with a bag of saline during rounds. And if any of you knows how long the medicine rounds can go, it can be quite a bit of time. So
That's right.
point being, you don't need maintenance fluids. So we'll just leave it at that. Let's get. I talked about CTs here. This is the point that I do CTs. We've already spoke about. Let's talk about Actually, let's talk about cooling or TTM. I'm just going to turn over to you, Adam. These
Yeah.
days, with the data that we have, what are your thoughts on 33 versus 36? Even though there was a study that showed 37.
Right.
What are you saying?
So this is part of the reason I love this topic is because I think 5 years from now we're going to have a different answer, and I love saying things and knowing I'm probably going to be wrong, and I think that's exciting, right? And so historically, I think about when I trained, we cooled to 33, and I think about what those patients were like. They were all shivering. They needed high dose sedation, which then made them sometimes paralytics, even, which then made them hypotensive and on norepinephrine because of the iatrogenic hypotension. And so they're on 5 or 6 strips. And then all of a sudden, we decide to cool to 36. They no longer shiver. They no longer need sedation. So they're no longer hypotensive. And I just remember taking patients that were on 5 drips, and now the exact same patient is on 0 drips. And so I cooled to 36. I think what really, really matters, and I may be wrong, is no fever, no seizure. Just make sure those two things don't happen. No fever, no seizure. And the other thing about it is you walk into the room, you assess if they're following commands. There needs to be no doubt in your mind. If they are not, then you start cooling. This idea of I'm going to re-examine them in an hour or let's wait till we get to the ICU, no way. Just make a decision, and sometimes the decision is if they got rock for intubation, then my answer is TTM. Then I'm just going to do it. I'm not going to wait for rock to wear off.
Right.
And hold sedation, obviously. And if they wake up, that's awesome. Then I can stop TTM.
That's so well stated, because I think look, it does take a lot to get TTM started. There's the pads and all the protocols and whatnot. But if you're going to wait, you're risking that this person is going to develop a fever. And while we don't have the concrete data to say that, we know that that's bad, right?
Mm-hmm.
Having a fever in a post-arrest brain is a bad thing. So every minute I'm nervous if we're not getting this person to either normothermia or 36, because there's always that potential for fever, and I know I'm harming my patient. So like you said, I started 36 is not that deep, and I've had patients who start to follow commands. Great. Guess what? We're going to turn it off. We're going to warm them up, get them toasty again so that they're comfortable. But waiting and being hopeful that we don't have to start this is just a delay, and you're risking a lot by doing that. And, I do think that the newer data that came out last year is going to push us now to even keeping the person normothermic. And so for those of you who are unaware, the TTM2 trial was a pretty interesting study, not a perfect study, but a pretty interesting study where they took patients and they basically prevented them from having a fever. Whenever their fever curve or their temperature curve started to increase, they actively cooled them down to normothermia, and they found some really, really good results with that. So I encourage you to take a look at those papers.
Yeah, I agree. And also the path, I know I hope it's okay. We're going to go a little bit late just because we had a hiccup to start. But the pathophysiology behind hypothermia is so fascinating too, that for those of you who like to geek out, I highly recommend looking into it. And the two key things is, number one, it decreases cerebral metabolic demand, right? And number two, it decreases reperfusion injury. Both things clearly good in the brain injured patient. And let's be honest, every single post-cardiac arrest is treated as a brain injured patient until proven otherwise.
Perfectly stated. Perfect. Protect the brain. The last thing, I would say sometimes the most misconstrued thing is neuroprognostication. You should not neuroprognosticate your patients early on. You shouldn't do it.
I don't.
Adam, I can't tell you how many times I've had a patient or I've had someone at the bedside say, oh, they're fixed and dilated, or, they're not doing anything, or they've been down too long. And, I'm not saying we don't want to talk to the family and give them realistic expectations, but you can't prognosticate at time zero, right?
Yeah. So what I tell the families is, I am not going to give you a prognosis within the first 48 hours, and you're not allowed to ask me. And it's just not allowed. There are clearly scenarios where they progress to brain dead, and they're brain dead. So we'll take those aside. But for the most part, I don't discuss it. I just don't discuss it. Yeah.
Yeah. I mean, there's data, and I think that maybe this data is a little bit overblown, where some people say even 5 days out after rewarming, you can neuroprognosticate. That might be a little bit too long. And we certainly have tools in our arsenal like MRI and EEGs and perfusion scans that give us a good idea so that we can talk to the families. And, while we can't be perfect about prognostication, we can be pretty good about neuroprognostication, telling families what to expect. Is your loved one going to go home and go on long walks and still play Wordle and all that stuff? Unlikely not. Are they going to be able to go to a nursing home with a trach and peg? Yeah, we can tell you with some confidence what that's going to look like. And sometimes that's enough for families. But the most important thing is you should not be doing that early on post-arrest for patients. And, like you said, you just tell the family, right now we're in a holding pattern. We're going to revisit things after we warm, and then we're going to do some tests and we're going to talk to you. Hopefully things get better in the interim, but here's the expectation. We won't be able to tell you until some time passes. And I like that approach for families. And it's not confrontational. It's just like, this is the truth, that we're not supposed to be telling you things because it can go in a multitude of directions.
Yeah. And I would say, what I do is I give the statistics for post-arrest patients. I talk about survival of out of hospital post-arrest and return to normal function. I give larger larger statistics. I don't fixate on whether their specific loved one is going to. So I definitely provide that information so that they understand we're in bad shape. Even best case scenario, we're in bad shape.
Yeah.
And the other thing is, I will use CAT scans. Let's create a hypothetical situation. I almost said hypothermia. Hypothetical situation, right? Where let's say the patient is whatever, they're in ARDS, their SATs are 70%, they're post arrest, and they have complete loss of gray white matter differentiation. I will use that CAT scan to tell the family if I think that they're going to die from whatever underlying is, then I will also explain that information because I think it's helpful.
Absolutely. There's certain things that you can look at to give, like you said, bigger statistics for your families. But it's just very important not to give the detailed information right up front because you just don't know. And I think we've all had cases where it looked really bad, but you went through the cooling and patients kind of woke up and they did a little bit better than you expected. I know I've had several of those cases, so it's just important not to upfront not to neuroprognosticate. Anything else, Adam? That's what I had for the things that I do in the next hour to two. These are ICU level type stuff, but things that I wind up doing in the ED, or if I'm in the ICU and the patient's stuck on the floor, things I try to get going early on.
Yeah, no, I think that's great. I'm just going to plug how important it is to ask about downtime and then what I call no CPR, subpar CPR, or good CPR, right? So good CPR would be EMS or a trained medical professional. Subpar would just be bystander. And I think in what the initial rhythm is, it just matters so much. And one thing I would say about shockable rhythm I think is interesting is if you give enough epinephrine to anyone, you'll probably eventually need a shockable rhythm. So it's really the initial rhythm that matters more so than anything else.
Good point. Please drop in your questions. This was meant to be interactive, and I think it has been a very interactive discussion. Manjit has a question. I'm going to put it up on the screen here. There we go.
Great question.
How reliable is neuron-specific enolase post-test, post-arrest? What do you think, Adam?
So, I can't give you a statistic. I sometimes send it. The idea is it's an enzyme that gets released when you have neuron death, right? And I forget the cutoff. I always have to look it up. But I think it's very helpful when you're trying to neuroprognosticate and understand the degree of brain injury on a patient. But correct me if I'm wrong. I think it's less so about neuroprognostication and more so about brain death. That I'd have to look up. But that's what I seem to remember.
I think you're right. And, the thing is, and I think it's a send out test for us. Mm-hmm. Do you know if we have it in? So by the time I get it back, I'm sort of already at the point where I'm using other tools to neuroprognosticate. And what I would say is if you have it available in house and you're comfortable using it as part of your neuroprognostication, then say it. But I got to tell you, I wouldn't use it in a discussion with the family. If we've come this far and we're doing everything and we're going through TTM, I would much rather just go through, rewarm them, let's prognosticate them, let's get some data in the interval. If something shows massive, gross macro neurologic injury, I think that's enough to tell the family without a blood test. But if it's something that you have in-house and you can run it and people feel comfortable using as part of their discussion, then yeah, I would use it. We just don't have it available, and then we don't use it that often. Let's see. Farhan says, I follow Pittsburgh neuroprognostication score. All right. So here we go. Let me scroll back here. Okay, so here we go. Here's another one. Vent setting, PCO2 value, and avoid oxygen. toxicity. I'll tell you, the PCO2 thing I was referencing before was a part of an observational trial actually done at Cooper with Brian Roberts and Steve Trzeciak, where that wasn't the primary thing they were looking at, but it was one of the variables they collected. And what was interesting, and this is just one of those things, if anyone knows statistics, when you do post hoc analyses on things, they're just hypothesis generating. No one should take this right now, what I'm about to say, and start using in their practice. But I know places are starting to look at this. Look at the PCO2. When you have a PCO2 that is too low, what's going to happen is your cerebral vessels are going to vasoconstrict. And if you vasoconstrict, right, that's going to be injurious to the brain. If you have it too high, I had it reversed. If it's vasoconstricted, then you're going to hypoperfuse. And if it's vasodilated, you're increasing your ICP, and that's not good. So what's the perfect level? We just don't know. In their study, they found that a little bit of permissive hypercarbia was helpful for patients. How much? We don't know. I'll say their number showed 54, I think, or 60. Don't quote me on the numbers. It's hypothesis generating. But what I would say is try to keep your PCO2 normal if you can for your person post-arrest. And always avoid oxygen toxicity. The data has been a little bit variable with regards to that, but like Adam said, you're having massive reperfusion injury to your entire body. It would just make sense to give the person the amount of oxygen that they need. There's no need to have that PaO2 of 400 if there's no oxygenation issues.
Yeah. The caveat I would say is the PCO2 was normal for them, right?
Yeah.
And so, and remember, this is the pulmonologist, it's all about the pH. It's not about the PCO2. Yeah. And there is some kind of, I think, has to do with this, but maybe not specifically. There's some really interesting evidence looking at the ECMO patient who gets put on circuit and has a massive reduction in PCO2, and in which case all of the kind of bad neuro things that happen to ECMO patients has an increased risk in that group. So we're talking about increased brain bleeds, increased stroke, increased seizure, increased brain damage, all. So I am aware if I have a survivable pH, I don't need to drop my PCO2 way down. Assuming it's kind of in their wheelhouse where they normally live.
Perfect. Yep. Absolutely agree with you on that. One more comment here. The NSE takes 72 hours as a send out. It does help it's just one tool. So we can all agree that it's another piece of data. Look, I'm one of those people that I like more data to integrate into my clinical acumen, because the more data you have, the more the puzzle piece fits. Look, and you're also talking to a family and you're potentially telling them that you want to stop supportive care on their loved one. Every piece of data is important. You can't walk into the room and say, I just have a feeling. I saw someone that looks like your husband before and he didn't do well or she didn't do well. Every piece of data matters. So to me, if I can get more data, it just helps me. And if the data doesn't fit, you don't have to use it. But when you're talking about something as serious as this, more pieces help you. Unless, of course, it's something on CT that's just catastrophic. I'm looking through the comments here. I think we nailed all the comments and we went over, but I got to tell you, time flies when you're having fun. I had such a good time talking about this topic with you, and audience members, thank you for putting all the comments in the chat and being a vital integrative part of this discussion. It was more fun. It was more interesting. And I get to see what you all are doing in your practices, and I learned from you. So thank you for that.
Yeah, it was really wonderful. Haney, I have a question for you. This has been by far the chattiest group, and Randy has not been present.
I know.
Do you think there's a relationship there?
Are you saying that Randy scares people away? Is that what you're saying?
I didn't say that. You said that.
I'm asking you if that's what you're saying. You're not saying that.
It really depends on if Randy is listening or not, because my answer would change.
I wonder if Randy even exists. For those of you who don't know,
it's just me typing over here.
I know. We have a lot of new people to the stream. There's a gentleman called, I assume you know him, so I don't have to make any assumptions. There's a gentleman named Randy, who's a physician, who has been on almost every single stream that we have ever done and has the wittiest, snarkiest comments. And we've come to, he's like the mascot of the show. And this show has had the most guests, the most commentary, and is not here. Ian London's here, and he is, look at this. He's LOLing. Does he know Randy?
I don't know. I don't know Ian London.
I don't know.
Maybe
Either
just
way,
through the show.
maybe through the show. We even talked about making T-shirts with Randy's head on it, just who's Randy? I think that would be the great tagline. Nope, no one knows where Randy is, but he's certainly not here. Adam, any closing thoughts before we let these people go have drinks, have dinner, watch Netflix?
Yeah. No, I really I think there's an art to taking care of these patients. I think that when a family member has their loved one die and then get brought back to life, it is very important to never show a disinterest in them, or this is futile, they're going to die, or they're brain damaged. I think it's important to come with full force, show that you're really trying to care for them and build a rapport, and just be honest as things go and listen to them. And I think that when some of these patients wake up and they do well, it is one of the most gratifying things we get to do, and it's really
Absolutely. And by that token, while we hate to talk about it, when patients get rewarmed and they don't do well, having that relationship with the family from the beginning, where you've been honest with them, you've been direct with them, and you can look them in the eye and say, we said what we were going to do, and unfortunately things are not looking the way we want them to look. It's not the outcome we want, but families are greatly appreciative of it. And I've heard those words before, and I know you have as well. It's just important to be honest and direct, upfront with your patients' families, and just let them know the things that you know, and not give false hope. That's a general thing in critical care, but especially something like this, because I do feel as though when we start the cooling, there's a clock that starts, and we know that in 3 to 4 days, we're going to have the answer to what's happening. What we think prognostically, we know it's going to happen. Then we have to just help the family through and see if that matches what their wishes are.
Yep, totally agree.
Man, we just ended this on a downer. Jeez.
Well, let's talk about what we're going to do next. Maybe that'll
that's a
get
good idea.
people excited.
Yeah, someone, look at this. Look, people are already expecting our next talks. When's your next talk? When is our next talk? Our next talk is going to be August 1st.
Are we doing 8-1? I think we're doing 8-1.
I'm going to be on vacation, but because I'm dedicated to the show and I'm dedicated to all of you, screw vacation. On vacation, I'm going to do the stream. Actually, it'll just be a nice, relaxing break from a bunch of screaming kids and crying and fit. So I'm actually looking forward to 8-1. What are we doing on 8-1, though? That's the question.
So I think we're going to call it something along the lines of which patient needs emergent transfer for transplant eval. Mm-hmm. So the two organs I think of for emergent transplant is basically going to be the liver and the lungs. And so what we're hoping is to get a couple transplant experts and some intensivists on. We may have 3 guests and chat about it.
3 guests. I'm gonna have to upgrade the internet here. I don't know if the internet can handle this, but
I just committed to something. Or I guess I'll take a seat then. I'll step out.
No. You are vital. I'll turn off my screen and just listen and laugh with all of you. All right. Well, everyone, thank you for tuning in. If you haven't already, please like the stream. Please subscribe to the channel so you get notified on any of the stuff that we do here and any of the comments. Thank you so many people. I think this is the most people we've had on the stream, and I'm grateful that all of you took time out and been part of this, and most importantly, that you interacted with us together. I'm trying to figure out what Ian's trying to say, but we're just gonna close the stream here, and we will see you on 8-1. Adam, thank you for being handsome and charming as always.
Thanks, guys. It was great.